Okay, thank you. Good afternoon, colleagues from all over the world, all over Africa. I'm called Dr. Daniel Byamukama. I'll be the moderator for the session. I work with the Uganda AIDS Commission as the head HIV prevention. Today, we shall be sharing with you our practices, what we do in the country in terms of HIV programming for key populations. And we shall specifically be sharing with you what is possible in public facilities. But first, give you a small background about Uganda. On the team, we have colleagues. I will ask them to introduce themselves. Some of the colleagues work with the development partners, including UNFP and UNAIDS. Others work for the ministry, and others represent civil society, but most specifically, key population-led organizations. So I would want to pause here and first ask the Ugandan colleagues to introduce themselves by name, the institution they work for, and titles. You can go ahead, Uganda colleagues.
Good afternoon, colleagues. I'm Rosemary Chinyumunda. I'm a program specialist at UNFPA, HIV, SRH integration. You are all welcome.
Thank you, Rosemary.
Good afternoon, everyone. My name is Richard Lusimbo, and I work with Uganda Key Populations Consortium as the national coordinator, and I'm happy to be here. Thank you.
Good afternoon, everybody. I'm Dr. Kyambadde Peter. I work with the Ministry of Health AIDS Control Program, and I'm the focal person for the Key Populations Program. Thank you.
Other colleagues online, Dr. Peter Mudiope.
Hi, everyone. This is Dr. Peter Mudiope. I coordinate HIV prevention at the Ministry of Health in Uganda. Welcome to this session.
Thank you, Peter. Do we have Macklean online? So maybe we could quickly give our guests, the people we're hosting, a chance also to introduce themselves to us. Since we are not many, I think we can do it individual, and I will do the roll call method. Yeah, I'll start with the, hello? Yes, there is another Ugandan, Comedian.
Yes, I'm Comedian Ahmedov. I work as a fast-track advisor at UNAIDS office, and my functions are mainly focused around HIV prevention and some resource mobilization areas. Thank you.
Thank you for joining in, Commission. Okay, now we've been advised, our guests, the people we are hosting, we can introduce ourselves. I think we are not a big number, so we can quickly, within 5 minutes, introduce ourselves, starting with the Lulama.
Thanks.
Our host, yeah.
Sure, thanks, Dr. Daniel. I'm Lulama from the South Learning Network. I support the program, and I'm based in Johannesburg.
Thank you. Maria. Maria, kindly introduce yourself. Paranita.
Hello, everybody, and hello, Dr. Daniel and Uganda team. I'm Paranita, and I work with the South Learning Network. I'm based in Nairobi, Kenya. Thank you.
Thank you. Next is Gina. Gina.
Yes. Hello, this is Gina Dalabetta. I'm with the Bill and Melinda Gates Foundation.
Thank you. Chris. Chris, it's good to have you. Chris, are you there?
Hi, everybody. This is Chris Jones from Man Global Health. Nice to be here.
Thank you. Dominic.
Yeah, hi, my name is Dominic Gondwe. I work with the National AIDS Commission in Malawi as a key population focal person. Yeah, nice to be here. Thank you.
Pindani.
Hi, everyone. My name is Daniel Pindani. I'm working with JAPICO as the key population program project officer for Chikwawa. Thanks very much.
Have we heard from Morana?
Hello, everyone. So this is Enoch Maulana, working as a key pop officer in Malawi under JAPICO. Thank you.
Boris. I see CAP Foundation for Professional Development, who is her Hanli.
Good day, my name is Hanli Kapp. I'm from the Foundation for Professional Development in South Africa.
Thank you.
Managing key population programs under the CDC funded sector.
Humphrey Dondo.
Thank you. Good afternoon, everyone. My name is Humphrey Ndondo. I'm the Senior Technical Specialist Key Populations with the National AIDS Council in Zimbabwe.
Thank you. Grace Kumwenda.
Good afternoon, everyone. My name is Grace Kumwenda. I work with an organization called Pakachere. We work with key population in Malawi. Thank you.
Thank you. Janet.
Good afternoon. I'm Janet Musimbi. I support the South to South Learning Network based in Kenya. Thank you.
Patrick. Goreth.
Hello. Patrick. I work with me.
Patrick, there is a challenge with the network. I hope it is not mine. And Wycliffe. Wycliffe. Okay, we can't hear. Wawira.
Hello, everyone.
Okay, the network is not clear either. Wawira.
Greetings, everyone. My name is Wawira. I'm with Man Global, Nairobi.
Thank you, Wawira. Falilai.
Good afternoon, everyone. My name is Tato Farirai. I'm with the Foundation for Professional Development in South Africa, providing technical support to the National Department of Health on key populations. Thank you.
Thank you. Gianni.
Hi, everyone. I'm Yanni Swart. I'm from Genesis Analytics based in Johannesburg. Thanks.
Thank you. Chongwe.
Hi, everyone. I'm Madal Chongwe, working with JAPICO, Key Population Officer, Malawi.
And we could hear from Mpaso.
Hi, my name is Mason Mpaso, and I'm the Key Population Program Technical Lead. That's JAPICO, Malawi.
Okay, it's a pleasure having all of you here in Uganda virtually. I don't know who, which name I may have missed. There's David. David, you've not introduced yourself.
Hi, my name is David Chirungozi. I work for FHI 360 EPIC project. We are in key population response here in Lilongwe.
Which country is this? In Lilongwe,
Malawi.
Okay. Anybody who may not have introduced ourselves, you can take this opportunity to volunteer and introduce yourself. 2 more minutes.
Yeah, thank you, Daniel. This is Pande Gerard from the Ministry of Health.
Yeah, this is one of our other colleagues who has joined us. So quickly, a summary as Uganda. Uganda, we are in East Africa, and we have a population of around 42 million people. But specifically of importance is that we have key populations in this country. And like most other countries which were former colonial or colonized, we have laws that we do not know where they originated from, but they really stigmatize and push key populations on the world. And I think that's one of the reasons why they are defined as key populations. But in spite of the laws, and in spite of the fact that we're a very religious country, there are so many religious practices, partners, including the ministry, innovatively continue to find ways of delivering services to key populations, services they need. Currently, we are being guided by the National Strategic Plan. We launched a new HIV and AIDS National Strategic Plan for the period 2020 to 2025. And for the first time, our National Strategic Plan is well aligned to international guidance in who the key populations are. It's not that we do not believe they are not there. We believe they are there. So the National Strategic Plan clearly recognizes the 5 categories of key populations, including prisoners, sex workers, transgender persons, men who have sex with men, and people who inject drugs. In previous national strategic plans, it was not so. Maybe the recognized key population may have been sex workers and later men who have sex with men, but now we are fully aligned with the national strategic plan. I mean with global guidance and standards. We recognize key populations as a key contributor to the HIV epidemic in Uganda, because based on the statistics we have, we believe female sex workers, who are the predominant form of sex workers, account for 20% of all new HIV infections. Female sex workers and their clients, men who have sex with men, they account for like 0.6%, and people who inject drugs account for 0.4% of new infections. But this is, of course, disproportionate, because as I will show you later, I will talk about it later, that we have done a key population size estimation. It is not very current, but we have size estimation at national level. How many sex workers do we have in the country? How many people inject drugs in the country? For example, we estimate that on average, we have 22,000 men who have sex with men in the country, with an upper confidence interval of 32,000. We estimate that female sex workers average around 130,000, with an upper confidence interval of 210,000. We estimate that people who inject drugs are in 7,000, with an upper confidence interval of 11,000. Significantly, our HIV prevalence in the country keeps coming down a bit, but for key populations, it doesn't significantly come down. So we are at an average of like 5.8% national average, but we still record high prevalence among these key populations. I can single out female sex workers. Our average is 31.2%. Men who have sex with men, the average prevalence is 12.7%. Prisoners, the female prisoners have a very high HIV prevalence, 34.4%. The male prisoners are 14.4%, and their bosses, the prison warders, are 12%. Transgender women, we stand at 20%, and people who inject drugs, we stand at 17%. So it is true, we have key populations in Uganda. It is true that we have the other challenges they face in most African countries, sub-Saharan African countries, including laws on books that call their practice or their uniqueness criminal, and unsupportive social norms, and to some extent unsupportive policies. But of course, as government of Uganda, so some of the things you may have heard about Uganda may not be true. There is a great effort in Uganda to make sure these key populations access the services they need. And as my colleagues will share, from the Ministry of Health, can imagine the whole Ministry of Health has a program committed to delivering key population services in public health facilities, which shall be the main focus of our sharing today. And even the policies, I've already shared with you that the National Strategic Plan clearly recognizes key populations and plans on what should be delivered to them. Even the Ministry of Health policies, from AIDS-related, HIV-related policies, reproductive health policies, they recognize. These are documents signed off by ministers, signed off by the president, which recognize that there are key populations and there's a need to deliver services. So in spite of the environment, there is an effort to make sure we reach these key populations of the services they need. And it is what we're going to share with you on how we do it through the public sector. And at this juncture, I would invite the head prevention, the coordinator for prevention in the Ministry of Health to take you through the first presentation. Thank you. Dr. Mudiope, the floor is yours.
Thank you, Chairman, Dr. Daniel Byamukama, and thank you, SSLN, for this session, what is happening in Uganda. And thank you, colleagues, for joining this session, especially our colleagues from the civil society. You've been there, you've been our partners in fighting HIV/AIDS among the key populations. The Uganda's roadmap has not been that easy. We started this key population program in around 2005, and at that time, it was really a big challenge. Government was working alone, and the civil society was also working alone, and government was not recognizing the problem then, maybe because also the burden in the general population was high. And the civil society was telling us, look here, there's a problem, but they could not demonstrate. So it was an issue of activism, and government went on the defensive. However, in 2010, government dampened a bit, and the civil society also was able to demonstrate. So in some of our surveys then, were able to capture some information on key populations, and at that time we called them most at-risk population, and the sex workers came in our strategic plan. However, at that time we still had challenges of recognizing the transgender and MSM. In 2014, when we had the AHA Anti-Homosexuality Act, that was the uprising in Uganda, and thank God that was repealed in Parliament, and it is not in implementation currently, but it made us have significant advocacy and support to the key population programming. And by 2015 and 2020, the key population programming was recognized and integrated into the HIV program in the country. And the communities of key populations were moderately strengthening, their capacity was strengthened, and they were able to migrate or move away from activism to advocacy, where they were able to demonstrate the burden of disease and the inability of government programs to reach those populations with figures. Ladies and gentlemen, with that introduction, allow me to present to you what is happening in Uganda, and in a contextual overview, Uganda has made very significant progress in the epidemic response. And if you look at the figures overall, we have achieved the 90-90-90 by 2020, and we moved on to 95-95. We have also observed the new infections also, and the AIDS-related death had declined by approximately 60% from 2010 to 2020. However, Uganda is concerned about the high burden of new infections in specific populations like the pregnant women, children, adolescent girls, men, and key populations. Next slide. So The HIV prevention among key populations specifically is critical and prioritized in the country, and the burden among these people remain high. The prevalence has been already given to you, and this is based on the brain survey that was conducted in 2013. And this year we are still conducting another repeat brain survey, and we shall give you more figures. We also did a serobehavioral survey among the prisoners, and the HIV prevalence was high, as the chair has illustrated to you, well above the national average of 5.8. You can see men who have sex with men, 12 female sex workers around 31, people who inject and transgender, and prisoners were all above the 5.8. Next slide. The HIV, at the national level, this is in a HIV programming at the different levels. At national level, Uganda AIDS Commission leads the multi-sector approach, but this presentation mainly focuses on the health sector HIV response in the country. And in the ministry, we lead the public health response, and it is based on the HIV prevention approach with biomedical and behavior. The structure approach is mainly integrated within the different government ministries, departments, and sectors. At district level, this is where we have effective implementation, and in the districts, we have the district health team that are supported by the civil society and the implementation partner. We also have community civil societies and community-based organizations and KP-led networks and peer support organizations that have mainly supported the key population programming at the implementation level. Next slide. So, what has enabled the programming in Uganda? The drug use, sex work, and same-sex relationship as a principle, they are still criminalized in the country. But however, remember that the national, the Ministry of Health is committed to providing key population friendly services. And in most of our policies and guidelines, this has been prioritized. Remember that the National HIV Strategic Plan is signed off by the President. That is the highest level or highest office in the country. And this strategic plan has fully integrated the issues of key population programming. And this applies to most other documents in the health sector that guide the implementation of HIV services, like the health sector HIV strategic plan, the National Priority Action Plan, the revised version of the consolidated guidelines 2018, and we shall be revising them this year. The national guidelines, we have also developed national guidelines for provision of KP-friendly services and harm reduction guidelines. We have several SOPs for provision of KP-friendly services, like the KPDSD, the DIC SOP, and harm reduction guidelines in the for people who use drugs. Next slide. There is a problem with my slides. They move a little bit slow. I don't know how, maybe animated them. So in a way of coordination, KPs are part of the coordination structures, and this is deliberate, right from the Ministry of the national level, to the lower levels, that they are part of the different subcommittees that advise the ministry. And on the same committees, we have representation from enforcement agents to ensure that certain circumstances prevail during implementation. For example, in the harm reduction subcommittees and the MAT subcommittee, there are representation from Uganda Police Anti-Narcotic Department, mainly to build capacity of their colleagues about MAT, such that they don't have errant arrests for key populations who come to access MAT in the facilities. The KP community also participates in the planning process, and as a result of that, it has led to expansion of the KP-friendly service delivery in the country. Almost 702 facilities that are government facilities out of the 1,500 facilities that offer ARVs in the country. The community also has representation on the Global Fund Country Coordination Mechanism, and this has resulted, of course, in increased financing and advocacy for key population services. Next slide. So implementation is done at the lower level at both the static and it's done at both the static and outreach, and mainly within the district. It's done jointly by the CBOs and the government facilities. We currently have around 702 facilities that are implementing key population programming, and this is fully integrated within the existing facilities. And this slide is an example to show you how district leaders have been engaged in key population programming, and also the national law enforcement and other stakeholders like the police, the prisoners, and all other district officials. I think this slide demonstrates that. Next slide. So the issue here is we have government-led programming, and this has been demonstrated by the establishment of pilot and model facilities within the government facilities. The MAT clinic at the National Mental Hospital is basically located within the mental government facility, and the head of that facility, the psychiatrists, are all government workers, and there is a clear integration. This is located within the alcohol and drug unit, and it is supported by the administration of the facility. We also jointly work with the community and the implementing partner. Another clinic that we shall have a presentation is the MAP clinic at Mulago, and we also have the MAP model rolled out in most of the regional referral hospitals and hospitals located within the hotspots, the KP clinics and the BICs. All these are supported by a strong community that generates demand and support for client follow-up. The bottom line is the joint government and civil society supervision and mentorship that are held frequently. So this is another slide that is showing how mentorship is done jointly between the civil society and government workers. And then there is the MAT clinic shown there, whereby the community engagement is led by the Uganda Harm Reduction Network, which is a PWID-led CSO, and it coordinates advocacy activities, recruitment of peers, sensitization of the PWID in the community on MAT, line listing of potential clients and referring, and also the IEC materials. But they participate in engaging community leaders and enforcement officers specifically. And I'm happy to say that next week we shall be launching another TC dedicated to MAT client next to the hospital, and we got this clearance from the local community because of the good working relationship. Next slide. Next slide. So this is one of the documents we are using. The toolkit for DSD for key populations is also a government document. Next slide. It provides how services will be offered to the key populations. So This is also about the package of services as they are provided for in the toolkit and other national documents. This is the minimum package. Next slide. I will not go into the details of this one. In terms of strategic information, we have previously done key population size estimates in 2013, and we did a key population synthesis. Back to the previous slide. In 2018, we did a key population synthesis. We have tools for capturing key population data, and we are now reporting data online from the facilities. Data is keyed directly into the key population tracker, and we have the longitudinal register for key populations, where data at the service delivery point is keyed in. We have some constraints. I've already mentioned the legal, culture, and administrative environment. We have the geographical scale and intensity not being up to scale, and we have the available guidelines and tools not adequately disseminated. There are issues of capacity and the within the system. I've already said that there is some improvement in the capacity of the community, but we still have some challenges. And also the KP tools are not yet systematically rolled out or integrated with the PHIS2. Next slide. I'm about to finish. This should be my last slide on the observations and lessons learned. The first one is that to counter this constraining legal, cultural, and social environment, government's leadership needs to be strengthened. It may create confidence and create an enabling environment for the response. It may be hard to repeal the law, but at least to implement it at the level of implementation. When you engage the police, they may not do the rampant arrests and harassment of the key populations. So they may come and seek for services without harassment or arrest. Then coordination with meaningful engagement of key population community is key. And also development of standard guidance is a bit, takes some protracted length of time, but creates a clear accountability framework and buy-in from different actors. Then the frequent and sustained presence of team through outreaches and increased community, this increases the community confidence and service uptake. And then follow-on continuous support supervision is also very critical. And lastly, a strong and vibrant community system is critical in successful delivery of KP-friendly services. I thank you so much, and back to you, Chair.
Thank you, Dr. Peter Mudiope, for giving us an overview of the structure of the key population response under the health sector or the Ministry of Health. And he pointed out that we implement a multi-sector response. So some of the interventions that he may not have touched, which fall under structural interventions, are implemented somewhere else, but we are focused on the Ministry of Health and its mandate. So we want to go specifically to share with you one of our best practices of how KP services are delivered in routine health facilities. And we are going to share with you next what we call the MARPI model. And it's presented by Dr. Kyambadde Peter, who is also staff of the Ministry of Health as under coordinating the key population response. Dr. Kyambadde, kindly take the floor.
Thank you. Thank you, Chair. Just to give a little background about MARPI. MARPI is a registered entity that is spearheading the key populations integration of the key population interventions within the public facilities. And this work started way back in 2008 in the National Referral Hospital Mulago. specifically under the National STD Control Unit. And this was informed by what was happening within that clinic around that time. The people in the clinic noted that there were quite a number of ladies that were attending the clinic recurrently. And when the team within the clinic tried to probe into who these people are, it was noted that these were sex workers from around the city, the Kampala city, and therefore it became, the team thought that it was really necessary, instead of waiting for these ladies to come for treatment, it was necessary to go to them in the communities and reach them and help them in the terms of providing information and the other interventions within their communities to prevent these recurrent STIs. But also, there was already information about the studies that had been carried out by the AIDS control program around 2001 and 2002 among the sex workers on the streets of Kampala. And these studies, this particular study was done by the AIDS control program itself. And it had noted that at that time, 2001, 2002, 48 out of 100 sex workers that were involved in that study actually had HIV. We are already HIV positive, meaning that almost 1 in 2 of the sex workers that were standing in the streets of Kampala actually had HIV. And trying to probe into who was specifically buying the sex, it was noted that almost everybody was there buying. The casual workers around town were buying sex, the professionals, doctors, teachers, everybody, of course, including the politicians. They have also been, including even the religious leaders, they had been cited in some instances by these populations that they were also going to them to buy sex. So it became a big concern for us in that unit, the STD unit, which is of course is part of the AIDS control program. And we started a smaller program around 2007 to reach out to these populations within their communities. And out of that effort, that's what MARPI, that's how MARPI was delivered, as an effort to mobilize more resources to deliver interventions to these populations within the communities. And it became a registered entity in 2008, but specifically spearheading intervention within the public health facilities, starting within Mulago, where we had already started work. And what you see in that picture is the National STD Control Unit. It harbors a clinic. And behind there, if you could look at that picture, there is some bit of blue at top. That's where we have the Key Populations Clinic, the MARPI clinic that serves key populations. The front part, we have a general STD clinic, but we also have a national STD lab there, and the officers in there, the staff. And that's how the setup is in Mulago for the MARPI clinic. And since then, that effort has been able to expand, to reach out, to expand the same model in the public facilities, in the regional referral hospitals, and the other strategic public facilities around the country to provide key population services within public health facilities. Next slide, please. The framework on which this model is based is around a friendly environment within the facility, the public facilities. Having a friendly environment within our government facilities, working very closely with the key population communities. And as I told you, we started going back to the community way back in 2008. So working very closely within these communities, together with the key population CSOs that do a great job of mobilizing these communities and also participating in the different interventions. And all this being linked through the people that we call peers, peer educators, that are selected from those particular communities, selected by the key population themselves, that act as a link between those communities in terms of either linking our clients to the facilities, following up these clients, and any delivering interventions that the facility feel that can be delivered by these peer educators. And this framework is operationalized through what I could say peers, what I could say pillars. And one of the key pillars is to ensure that you create an enabling environment. And later on, I'll go, of course, a bit in detail in each of these pillars, but one of them is creating an enabling environment in the provision of services. Secondly, the second one is capacity building, ensuring that the people that are involved in delivering these services have their capacity built through training, through mentorships, and of course, through support supervision. Not just for the healthcare providers alone, but also within the communities, building the capacity of the peer educators and other peer navigators within these communities. And the third pillar is that of ensuring that the services are integrated. You do not just deliver one standalone intervention, but the services are delivered as an integrated package, but also integrated within that particular facility. And these services being delivered jointly between the healthcare providers in the facilities and the communities that benefit, the beneficiaries of these services. And of course, we have been able to move from just drop-in centers that are located within the government facilities to have also drop-in centers within the communities that are managed by the key population CSOs, the key population themselves, managing and working very closely with the facilities to deliver. Therefore, that integration in the delivery of these services is very, very critical. And the fourth pillar is that of ensuring that you keep your eyes and ears on the ground, because key population issues are still very, very sensitive in our communities, particularly in Uganda. It may be a bit different in other countries, but in Uganda, issues of key populations are still sensitive. And therefore, keeping your ears, not just ears to hear, but also eyes to see what is happening within the community is very, very key. And using the data to ensure that we keep improving the services and also informing the way we scale up the program. Next slide, please. Pillar one is that of creation of an enabling environment. And as I said before, this is one of the critical pillar in ensuring that the services get integrated and are provided within the public health facilities. And under that, it is important to make sure that the key decision makers, for example, the AIDS control program and the people within the Ministry of Health itself, are engaged and they are supportive. Therefore, getting a buy-in, because in our previous HIV program, we did not do a lot about particular populations. The assumption was that if services are provided, everybody should be able to access these services. But of course, along the way, it was noted that even if services are very close to certain population, they may not access them. And therefore, involving the decision makers, the ministry itself taking the lead in delivering and supporting these services is very key. And in Uganda, Ministry of Health is very supportive. We have been having a desk, a key population desk, way back in 2008. And in Uganda AIDS Commission, we also have support there. Actually, one of the multi-sectoral TWG meeting in Uganda AIDS Commission sits in Uganda AIDS Commission. And of course, we have a TWG technical working group within the Ministry of Health. And therefore, getting that particular support within the sector itself, the health sector itself, and the multi-sectoral response is very, very critical to drive the key population's response, but also to ensure that you get acceptance within the public facilities to be able to integrate the key population services within these facilities. And of course, you don't, using our model, the MARPI model, you don't just focus on the health sector alone, but it is important to also engage other stakeholders. The enforcement agents are very critical because for them, their job is to enforce the law. And therefore bringing them on board is very critical. And from our experience, we have noted that when you bring them on board, they actually become very positive. In all the work that we have been doing, we have been engaging them and they have extremely been very supportive. Recently, when we are starting the MAT clinic in Butabika, National Referral Hospital, this is one of the commissioners has been extremely supportive in ensuring that we come up with the policies and also address the law that the Anti-Narcotic and Psychotropic Substance Act that affects which of course criminalizes the people that use drugs, has been at the center of this in ensuring that the law enforcement agents are not there to arrest, but to be supportive in terms of provision of services. And of course, the way the system works in Uganda is that from the Minister of Health, we have districts which are the front line, which are actually at the front line of delivering services. It is extremely important that you cascade the creation of the enabling environment to the lowest level. And therefore, getting buy-in from the district health officers and the regional referral hospital directors is very, very key. But also bring the politicians and the other technocrats within these districts is very critical to ensure that they are part of the support to ensure that these services are provided. And religious, cultural leaders, and of course, other gatekeepers within the community. And this is how we've been able to move in the area of creating an enabling environment and be able to get the acceptance within these public facilities and in the communities themselves to deliver these interventions in public health settings. Next slide, please. The next pillar, of course, as I said, is that of building the capacity through trainings, mentorship, and placements. And as you can see in that picture, we train healthcare providers, but we also train peer educators. When you look at our training curriculums in the medical schools for the nurses, the doctors, and the others involved in delivery of healthcare services, there is nothing like a key populations. And therefore, people know nothing about key populations. And therefore, for you to introduce the program within our public healthcare facilities, it is important that the healthcare providers get engaged through trainings, through mentorships, through placements, and build their capacity. And what we have noted that common at the beginning when you engage them, for example, during these trainings, the first day they are very negative, which of course would not blame them because the stigma towards key populations is almost everywhere within the communities. And the healthcare providers are part of the community. And therefore, they also have that stigma towards key populations. But after engaging them, trainings and mentorships, you note that their attitude actually changes. And therefore, that is very critical in integrating these services, the key population services, in public health facilities. You don't just bring a program before building the capacity of the healthcare providers, but also building the capacity of the communities, the key population communities, through training the peer educators, but also having dialogues within these particular communities. Next slide, please. The third pillar is that of joint delivery, which I already talked about, that we need, whether you are delivering services within the community or you are delivering services within the facility, key populations prefer a one-stop center model, where once they come for accessing services, you almost offer everything that they need. Of course, that is not possible that all services can be provided in one stop center, but the critical services for HIV are you can be delivered as through a one-stop center approach. And therefore, in most of our facilities, in what we call facility DICs, we ensure that when a key population comes, a client comes from the key populations community, is able to receive the entire package of services from that one-stop center, right from prevention to treatment, including psychosocial support. And of course, we are in the effort to ensure that we also add in the mental health care, the mental health services, because of course, mental health is one of the issues that originally we had not thought much about, which is also getting integrated into these one-stop centers within our facilities. But also similarly within the communities, when you go to deliver these services, the effort should be towards ensuring that you deliver a comprehensive package. And of course, as we deliver these services, the healthcare providers do not work alone. The best is that you must at all points be working with the key populations, the key population peer educators or navigators that the key populations themselves have selected. Next slide, please. The fourth pillar, of course, as I said, it is always important to listen to what is happening within these communities, but also to hear what the different stakeholders are saying. Sometimes, as I said, key population issues are still very sensitive in our community. And therefore, keeping your ears open and even going into these communities and exactly seeing what is happening within these communities, it is very, very key. Gathering information, and of course, understanding that information and be able to dialogue over the issues that arise within these communities is very, very important for sustainability of these services within the communities, but also within the facilities. Next slide, please. And of course, as you do all of that to deliver, to ensure that these services are provided within the government healthcare settings, it is important that you collect data. And currently, as my colleague Peter, Dr. Mudiope said, we have now tools that have been developed by the Ministry of Health that collect data specifically from the key populations. And as you go on, you keep analyzing, looking at this data, and use the data both at the facilities to see what is happening along the delivery of services, the entire cascade of prevention, care, and treatment, and not just looking at the mass data, but at the facility itself, see what is happening in each of these individual facilities to ensure that you put up interventions to bridge the gaps in the service delivery for key populations as they arise in each of these facilities. And of course, be able to report. Currently, we have a system, which is the KP tracker that was developed by one of our partners, PEPFAR partners that we are using, which develops, it's basically like an electronic medical records that captures pre-primary data. And that is entered within that tracker at facility level, but also the Ministry of Health system. The data is to also captures some of the indicators that we do use for reporting and also for informing program. So as we scale up and as we integrate these services within the public health facilities, one of the key things that you need to take a note of is gathering data, and therefore developing tools, having tools in place that can capture the data as you deliver these services is very, very critical. And that's one of the key things that we have been focusing on. The first tools, of course, were developed by MAPI, but now they've been updated and taken up and as national tools. And that's what is happening in all our facilities across the country. Next slide, please. But doing all of that, as MAPI, one thing that we've noted is that a supportive environment from the Ministry of Health and Uganda AIDS Commission as key agencies that lead the health sector is very key if you are to integrate key population interventions or services within government health facilities. And as you can see in that picture within that slide, one that is Dr. Lusimbo, one of our commissioners in the ministry, and was actually talking to some stakeholders. And one of the things that he said it is true that we have made progress in the HIV prevention in Uganda, but we need to address the needs of key populations. And that is very important if it comes from the mouth of the leaders within the health sector. And therefore, if you are to integrate these services, the ministry, I would say, should take lead. And the Uganda AIDS Commission, of course, that coordinates the multi-sector response is very critical, because the key population response is not just a health sector issue alone, but it requires also other sectors to come on board and be able to support the program. And therefore, having that critical support from the Ministry of Health and Uganda AIDS Commission is very, very critical for the success of the program. And providing the leadership and the stewardship of the program is the key, not just within the ministry itself alone, but everywhere at the district. In our setting, we have leadership at each of the districts. We have a district focal person for key populations. And in the facilities that are providing services for key population, there is a focal person in each of these facilities for key populations. And this ensures that when there are, for example, discussions within these facilities regarding service delivery within the facilities, the focal person also ensures that the key population issues do not get left behind. And that is very important. And as ministry, we have recommended that in each of these facilities that provide services to key population, there must be a key population's focal person, who is commonly the in charge of the facility. And we have noted that is very, very important for acceptance of these services within the public health facilities. And therefore, it is something that we must not ignore when you are integrating key population services in public health care settings, the leadership. But also we have gone further to ensure that within the communities, there is also leadership. And the key populations have taken it up very seriously in Uganda. And we have, for example, the Uganda Key Populations Consortium that brings all the different key population CSOs and many, many others together that are those that have the interest in delivering of services to key populations. And therefore, leadership and stewardship for the program is very, very key. Next slide, please. Next slide. Just quickly, this slide is not clearly visible, but what we wanted to bring out is to show you that yes, delivery of services, key population services within public health facilities is possible. We just picked a few of these slides and looked at the data between January this year, 2021, to around September. And we looked at prevention specifically. This is the testing there was one for PrEP, and if you look at PrEP, for example, you could actually say the uptake within the facilities, and many of these people that are provided the PrEP are actually key population. This particular data is specifically for the key populations, and you can see the uptake of PrEP, people who have been screened, over 17,000, those that were found eligible, around 9,000 plus, and those that have been enrolled and currently still taking PrEP in these facilities, close to 8,000, 7,800. Next slide, please. And this slide is specifically intended to share with you still regarding uptake of services within the public health facilities. If you look at prevention in total, among these facilities that we are sharing with you, there are about 15, 16 facilities. They were able to reach 56,330 key populations with the prevention. And among these that were reached with the prevention, 51,000 plus were tested, and close to 1,998 were found to be HIV positive. And of course, it is our policy, once anybody is identified HIV positive, it must be linked to care. That's one of our policies. Once you identify positive, it must be linked to. So this is clear evidence that yes, these services can be provided within public facilities, and the acceptance and the uptake is also building and increasing day by day. Next slide, please. This is just data from one clinic here at Mulago, just trying to look at HIV care between April and June this year. And it just shows you how many people were in care at this clinic. It is almost close to 1,500 clients, key populations, the transgenders, the sex workers, the men of sex with men, who have been accessing care from this one clinic here in the National Referral Hospital in Mulago under MAPI Clinic. And if you go down, of course, viral load is one of the key things. Those that have had their viral loads done, we note that the viral load suppression among these populations compares well with the general population. And therefore, it is true that these services can be provided and that the key populations can also adhere to treatment as good as the general population, as evidenced by the viral suppression here. So next slide, please. Of course, as we expand integrating the key population services in public facilities, there are also still challenges. It is true, it is possible these services can be provided within the public health facilities, but we still have those challenges which we may not do away with today, but it is just a continuous process. Of course, stigma, political, the negative social environment, and of course, the coverage is still an issue. Not all facilities have yet become on board in terms of providing services, but day by day, we are expanding these services. And of course, collection of data, strategic information, we still have gaps here and there, which we are working on. And policies, updating our policies, we still have gaps here and there, but this is a continuous process. Next slide, please. We continuously address these issues regarding, of course, the political, social, and the legal environment. It's not very easy to change. It may not change today or tomorrow, but it is continuous effort to ensure that we impact on this negative environment. But also we continue engaging the different stakeholders, engaging the communities, and of course, addressing the human rights issues. And our gaps within the M&E systems, we have improved a lot. And of course, also focusing on generation of evidence to continuously inform our program. And of course, the research itself. Next slide, please. So I think that is basically was our last slide. But in the summary, it is true, these services, key population services, can be provided within the government facilities. If you go through the processes that I've been discussing with you, it is really possible to have these services provided within the government settings. But the leadership of the government, as I said, and the leadership of the health sector is very, very critical. Just to acknowledge all those that you see in that slide that have been supporting us to ensure that we extend these services through public facilities to our key populations. Thank you. Back to you, Chair.
Thank you, Dr. Peter Kyambadde. There are a couple of questions that have been generated by your interesting presentation. And as Dr. Kyambadde highlighted, this work is more effective and meaningful if we are engaged with the communities themselves. It's one of the key hallmarks of this model. And I don't know if there are any questions. So there are questions in the chat. I would request Dr. Peter Kyambadde and Dr. Peter Mudiope to be looking at these questions. And we request our audience to allow us to share with you the perspective of the civil society, of the communities that we work with in implementing these models. We don't want to give you the only side of government. Let the communities also give you our perspective, and then we can engage into a discussion. We hope at the end we shall have shared with you how it is like in Uganda, and I know we shall have shared some of the things you never thought were possible in Uganda. So I would like to invite, I request you, any questions you can put in the chat, or you can hold on for the next like 15 minutes. We shall hear from the community perspective. I would want at this moment to request Richard Lusimbo and Macklean to share with us the perspective of the community regarding the services we offer.
Thanks so much, Dr. Peter Mudiope, Dr. Kyambadde, and Dr. Daniel. Before I get to our presentation, I just want to call upon my colleague, Macklean, who is now on the call, to introduce themselves, and then I will take lead on the slides. Macklean. Macklean, could you unmute and introduce yourself?
Hello, Rich. Yes, please. Good evening from Uganda, and how are you? I'm Kyoma Macklean. I work with the Alliance of Women Advocating for Change, and happy to be here. Thank you.
Yeah. Thank you so much, Macklean. So colleagues from the community, it's Macklean and I, but quickly we'll speak to the following. As Dr. Peter Kyambadde has presented, so we'll be limiting our presentation on how the model is working within the communities or with the communities. So MAPI has easy access to HIV information and services. Given our historical and legal environment, it was very difficult to actually even do share information or even services for communities, but now through MAPI, that has been eased because also the establishment is within the government setting, which has also given us leeway to actually do effective programming for the community. The integration has paved way to have a holistic approach towards providing access to HIV services, the KP community in Uganda. MAPI has also ensured continuity of services that would be far by the issue of missed appointments that would underpin poor adherence on ART. And I think, as you can see from some of the data that Dr. Kyambadde presented, also shows that we have made some progress. So quickly, that's in summary what really this model has done. But let's also go to the next slide and see how this model really works when it comes to the community. So three on this slide, I have a couple of elements. So we have MAPI at the center, And then we have the different components on the sides. So I'll start with the drop-in centers. So like Dr. Peter Kyambadde mentioned, we have facility-based drop-in centers attached to MAPI, and those are within different regional hospitals across the country. And these were an addition from MAPI clinic that is at the National Referral Hospital in Mulago in Kampala. But also we have community DICs. These are KP led and run DICs by KP communities. And these DICs help to drive the demand and also guide people and build a referral system where communities can refer community members who need services that are not provided at the drop-in centers. But also we have what we call the component of community outreaches with KP-led CSOs. So again, MAPI does conduct outreaches, for example, in administering, in supporting communities to administer PrEP. So again, MAPI works with communities. I remember there was a time when the anti-homosexuality bill had been passed, even when it was nullified, it was very difficult to do services. And now communities work together with MAPI to actually ensure that services are delivered to communities. And through this, no single day really went without services, because there was a relationship, and but also there was representation of government or Ministry of Health in these outreaches. And we have also seen there's a time an outreach was held in southwestern Uganda in Ntungamo, and after the police raided the area, but because MAP was there, so we're able to have our community members released. Again, these are some of the issues that continue to work to happen. But again, because of this relationship and model, we're able to work it out. So the other component is around KP-led organizations. So again, KP-led organizations do provide or do supply the demand to MAPI clinic, and these are KP-led CSOs that do not have necessarily drop-in centers, but they do referrals to MAPI, and then our community members are able to receive our services. We also have KP-led CSOs outside Kampala. Again, these play a critical role to ensure that our community members are able to be linked to services, and this is also through working hand in hand with MAPI. Let's go to the next slide, please. So I'm going to use this slide to talk about the challenges, but also help us understand why it's critical for the community to play a central role if we have integrated services, but also why it's important for government programs to work directly with communities to ensure that there's maximum utilization of services. So currently, not all MAPI clinics are full functional. And again, this is a huge model. If you're putting it across the country, there's a need for resources. So again, some of the clinics, MAPI clinics have been established, but they're not yet fully functional. And this is something we hope could be addressed and in the nearby future. There's also inadequate availability of STI medicines. Most of services provided were predominantly on HIV prevention and care. This demonstrates that integration of SRHR, for example, component of STI treatment is primarily missed in this community initiative. And again, this is a huge issue. While we may be focusing on HIV, but communities have other issues that need to be addressed vis-a-vis HIV prevention and care, and STI treatment is one of them. And there's high demand, and sometimes this is not available. There's also inadequate access to family planning services. As we all know, this is part of an SRHR service component that is also provided at MAPI, but during the lockdown, this was disrupted. And these family planning services is to be provided in MAPI initiatives and really focus again on prevention and treatment services in communities. Again, MAPI is a strong component, has a strong component in the central region, or because the headquarters of MAPI are here at Mulago, and also in Kampala in particular. But this is explained by the presence of well-established community-led KP organizations that refer clients to. However, more needs to be done in upcountry areas, such as Arua and Bara and others, where KP-led organizations have not been strongly well-grounded. So again, this we put up this point to also show that where there is strong community engagement, where there's strong coordination of communities, this model works very well, because then people will be guided to where to access services, but also people will be engaging the facility. And that's why you see that while we may be working better in some areas of the country, some areas there's a lot of work we need to do to ensure that, one, while we're building and having all the facility, the services, we need also to have a strong community that surrounds the facility in order to enjoy from the services, but also for the facility to actually operate to the full operation levels. And lastly, lack of friendly services and poor attitudes of health workers towards key populations, particularly in Bara. And again, we put up this point to really also show that we still have a long way to go. And I think, as you saw from Dr. Daniel, Dr. Peter, and Dr. Kyambadde, we still deal with the legal environment that has necessitated the pride and prejudice against KP communities in Uganda. And again, you find that sometimes some healthcare providers still have those negative attitudes, and we've seen some areas like Bara where our community members have been mistreated or not been able to get a service because of poor attitudes. But again, these are issues that are on the table for discussion, and there are different components that the ministry is putting in place, like training manuals for health workers when it comes to access of HIV services by key populations. And we are hoping that through this and these curriculums, it should be able to help us to deal with some of these issues. It's something we aspire to see better services, and we hope that this will lead us to where KPs in Uganda are able to access services without any stoppage. Thank you so much.
So thank you, Richard. Thank you, our audience, for being patient with us. Some of the questions you have raised, I'm sure, have been answered online. So we are ready to engage in a discussion for clarifying any questions you may have for clarification. But as our sharing has shown you, we indeed have key populations in Uganda. And we offer these key populations services, the services they need, including the key population friendly services, as has been defined by my colleague, Dr. Kyambadde here. Key population services, they are friendly, like we define youth friendly. That means the staff and even the equipment, the supplies, what you have, it means you have deliberately thought about the needs of the key population groups, but even the staffs are friendly and they are trained and the environment is safe. They don't feel threatened. We also have shared with you that we have a model. This model, as my colleague Dr. Kyambadde said, initiated from the National Referral Hospital, Mulago Hospital. After proving effective, we have scaled it up across the country to various centers following the MAPI model. But of course, this is supported by various initiatives by the community leaders, community representatives, and the other social structural interventions which are not directly under the Ministry of Health mandate. Challenges remain, as we have shown you. It's good, you've heard from the perspectives of the community representatives. Challenges remain, but as Dr. Kyambadde and Dr. Mudiope showed you, there is progress, we are making progress. We discover that when we engage, for example, when we engage the policemen, they actually are supportive. We discover they are supportive. So we hope to continue with this work and scale it up across the country. And as the last presenter shared, we have not reached the whole country. Key population services, Uganda has 136 districts. So key populations are still centered in the major districts, but we are progressing as we conquer. We have already a formula. We discover that when you engage the religious leaders, engage the political leaders, you turn them into allies, and we intend to continue with that formula we hope in the near future, Uganda will be a completely key population supportive community where key populations are entitled to their rights and they access the services they deserve. So what you have always heard about Uganda, that we crucify key population leaders, it's not true. My colleagues have shared with you that from the coordination structures, from national level up to district level, key population communities representatives are represented. So the tales of Uganda crucifying key population, some of them are not true. Though they are here, incidences here and there, but those are motivated by personal prejudices, not a systematic national. So we open this discussion to questions, and I'm ready to take the first question and provide you with clarifying information. Thank you for being a good audience. We can try to answer some of the questions that they shared in the chat as we invite, as more people put up their hands, those who have questions. Hello. So, any questions? Yes, Maurana.
All right. Thank you so much, Chair, for giving me this opportunity. And thanks so much to the presenters for the great presentations. We have really learned a lot on how you guys are doing in Uganda. So I just want some clarification on a few areas. The first one is to do with the DICs. How many DICs or MARPI clinics do you have in Uganda? And service provision through DICs, we understand KPs, they do come at a clinic and then get the services. So how are you reaching out to those KPs that are in hard to reach areas? Are there any outreach activities where you are bringing out these services to the KPs in the hard to reach areas? The other one is to do with the peer educators. It's one of the pillars that you mentioned that you're using, and as well in Malawi, you're also engaging peer educators. So I want to understand the link that is there between the peer educators and service provision. Are they empowered to refer their peers to the facility for different services? And how are you tracking this kind of referral from a peer educator to a peer and then reaching out to the facility? How is the referral being tracked by the programs in Uganda? Thank you so much.
Thank you, Marana. Any other questions? I would like to invite Dr. Kyambadde from Ministry of Health and MAPI coordinator. You can be preparing to answer the question presented by a colleague from Malawi. Any other questions, colleagues? So you can tell us now, we can clarify even the rumors that you had ever heard about Uganda. You're free to ask us if indeed there are laws that were passed recently to crucify key populations. Would even answer that one. So Dr. Peter Kyambadde, kindly share with our colleagues from Malawi, how many DICs, how many MAPI clinics?
Yes, thank you. Thank you, Maulana. The number of DICs, drop-in centers under MAPI are about 23, and these cover all our regional referral hospitals and some other health facilities below that level, below the regional referral, but facilities that are located within strategic places where we have high volume, a high population of key populations. For example, the border points and some stopover points for the longer distance truck drivers. These are majorly some towns where we have huge huge large numbers of truckers stopping, resting points where so those are some of the areas. But because this model is not just driven by MAPI, it has also been the other partners who have implementing partners in Uganda. The HIV program is delivered jointly with the implementing partners that are supported by our donor community, PEPFAR, Global Fund, the UN agencies. So they have taken up this model in a number of facilities. And I think Gerard, you are here. He monitors how many facilities are providing. But I think we have over now 300. Gerard, you can say more to that, where we are now, the number of facilities that are providing key population services, those that we have in our tracker, which are reporting. So it is a model that has been expanded, and we continue expanding it, and we hope that this model will be able to reach all the facilities. So already our implementing partners are using the same model in terms of delivering services to key populations in the facilities that they do support. How do you reach the key populations? Yes, of course we are relying on different approaches. One is that we have those that come direct to the facilities to access services. We have those that referred, we have those that are referred from the communities by the peers within their communities to come and direct to the facilities and access these services. But the majority of the key population that access services are actually seen within the communities. So we have outreaches from these facilities that go to the communities, and these two outreaches are conducted jointly with the key population community through the peer educators. The peer educators do the community mobilizations, and then the healthcare providers from the facilities go to those communities and they join those peers after the peers have done the community mobilizations, and then services are delivered at those agreed points within the communities. But also our key population CSOs have opened up drop-in centers within these communities, and these drop-in centers within the communities that are managed by the key population CSOs are also serve as sites where services are provided. Lusimbo will talk more to that, but we have quite a number of, for example, I think in Kampala we have over 20 of these community DICs where healthcare providers jointly go and provide the services together with the KPs, with the peer educators and our CSOs. Then the tracking, you have a clear referral mechanism, and we also have referral forms. When the peers refer clients to the facilities, they give them a form, which is, I think that's for a quadruplicate. They keep a copy with themselves. The clients can bring 2 copies, and when they are seen, a copy is signed, which they take back, but also the facility retains a copy. So we have a very clear mechanisms. We have tools, we have developed tools for the key population. They document all the services that they offer. Though these tools have not yet been approved by the ministry, but we're in the process of final, because different community players are using different tools. But we are working on this. We are going to harmonize our community tools so that we properly document the efforts within these communities. So that tracking of clients from community to the facility and back from the facility to the community does exist. And of course, these peers are also linked to these facilities. But also the key population DICs are supervised by the facility. If that KP is within the catchment area of that particular health facility, it is a responsibility of that healthcare facility to supervise that community DIC, which is run by the key population CSO. I hope I've tried to answer, but other colleagues can come in and beef up. Thank you.
Yeah, thank you, Peter. To be exact, the facilities that are reporting under PEPFAR, there are 279 facilities. This means that these are the facilities providing key population-friendly services. That 279 plus the 23 or the 24 plus MAPI. So those are the facilities reporting. For the community DICs, we have about 56 community DICs. Yeah, thank you.
Thank you, Gerard and Peter. Dominic,
Yeah, thank you, team, for the comprehensive presentation that you have made. Malawi, just like Uganda, is also a conservative country with over 90% of the population identifying themselves as being religious. One of the challenges that we face is that, yes, the government gives a go-ahead to for service providers as well as means of health to reach out to key population. But now when it comes to engaging politicians so that they can review some of the outdated laws, they are most of the times reluctant to be seen to be discussing issues of key populations because they're afraid of losing votes since the majority of the population is conservative. So we have had a challenge. When we want to meet them, most of the times they request that we meet them in private somewhere else. And most of the times the meetings we end up postponing decision making, okay, because they are always mindful about their voters. I don't know if the situation is any different in Uganda. And the other question, when you're making presentation, you talked about the HIV prevalence amongst prison officers. Does your KP program consider prison warders or prison officers also as key populations? Because the situation here in Malawi is that for prison officers, they are part of the uniformed forces together with the police, the defense force. Yeah, and as uniformed forces, they are regarded as a vulnerable population, but not necessarily key population. Yeah, that's what I wanted to know. Thank you, and over.
Thank you. My colleague Rosemary, would you want to have a go at that? At least the one on engaging politicians, and if you want, it's on the definition of prisoners as key populations. Rosemary.
Thank you, Dan, and thank you to Dominic for that powerful question. I think there are two levels to this. I did indicate in the chat among the key enablers was the fact that the Ministry of Health acknowledged and took a stand to a public health response. And that supported the technical teams to develop the necessary tools to engage KPs and provide the service. That does not necessarily mean that at political level, it is something where we have consensus, it is something that sells, but it is happening. And from what the colleagues have indicated, we still operate under that public health response. But when you take 3 steps towards addressing the human rights issues around it, you definitely take 2 behind as you meet that kind of resistance. But I've seen the changes happen over the years with persistent advocacy, especially from the funding sources, when they get an entry point through a signed national document, like they've mentioned. You have a national strategic plan signed off by the president. It mentions KP. You have other documents that are also signed off. So you have a cover for the health workers who are providing a service when they are trained, but you also use that to mobilize resources and you get a platform. And I did mention that platform that came with the Global Fund CCM as the one platform that has really made a big difference, because if KPs on CCM say that this country proposal can't be submitted the way it is, then it can't be submitted. And increasingly we hinge on that to continue with the advocacy at different levels. We have people who even go to the Interreligious Council, the highest seat, and present issues so that they can understand issues from different perspectives and address them as part of their processes. So it is a slow process, But once you have committed actors to do the advocacy, to demonstrate the benefits that come from action, even through the public health route, then to engage the key populations themselves, then there are small steps that are taken even at that level. Colleagues can add.
Thank you, Rosemary. I think you have really addressed this very well. I think the situation is not different from Malawi, but as Rosemary says, we have innovatively found a way of going around this by the Ministry of Health taking a stand, adjusting its policies to prioritize key population following the science. Then if we are to engage the populations, I mean the politicians and the church leaders, we face the same challenges like we face in Malawi, but I think there are inroads for us. There are some religious leaders who are supportive. There are some political leaders who are scientists who easily conceptualize this. So our response is purely on the support of the health sector, saying we are making a stand and we are free to deliver the services. The politics is the same. You must have heard that recently the government of Uganda, politicians had passed a bill that was adding salt to injury, but fortunately the president refused to assent to the bill. So the challenge of politics and religious is similar. The other question is, yes, in Uganda, key populations include prisoners, and because the prisoners and their bosses access services from the same facilities, usually we capture them together. But in real definition, like in Malawi, prison officers are under uniformed personnel and they are priority populations because there is no law or any policy that puts them in the disadvantaged position as related to the people they preside over. Peter Mudiope, you wanted to add something? Can you add something? Dr. Mudiope?
Yes, thank you, Mr. Chair. Thank you, Mr. Chair. I just want to say that the case of Uganda is a bit interesting. We have the legal and the social income balances, but we also have some commitment which supports key population programming, especially at the policy level. So it's mainly a question of stigma within the population and a question of acceptance of the behavior or the acts. But in terms of allowing to access services, there is a general consensus. And this is evidenced in our national HIV strategic plan. It is signed off by the President of the Republic of Uganda, and he signs off clearly that these populations have a problem. They are included in the strategic plan, and the President reads through with his advisors and signs off that yes, health sector or the market response should address the issues of key populations, of MSNs, of sex workers, and of PWD. And in one of his speeches, he has even clearly stated that one of the challenges of the youth is use. And to set up rehabilitation centers for drug use. So at that political level, they agree that there is a challenge and they want it to be addressed. I thank you, Chair.
Thank you. I see Pindani.
Thanks very much for recognizing me, Dr. Dan. It was really nice presented to us. In fact, we've been hearing a lot from the social media, maybe reading a lot from issues to do with the key pop in Uganda. Maybe some people may be arrested, say no, you should be in the house arrest up until you give birth to something else. So my question is to say, how are you engaging the law enforcers in providing the key population services to the key population in Uganda? Thanks so much.
Thank you, Pindani. Actually, you bring up something interesting. One of the technical support we are receiving from the South Running is to develop an advocacy tool for engaging all the gatekeepers. There has been significant engagement of key gatekeepers and law enforcement in the country. In the pictures, in the presentation of Dr. Kyambadde, and I think Dr. Mudiope also talked about it, we have been in a non-structured way engaging some of the law enforcement officials. And surprisingly, when you engage them, if there is a district police commander who is hostile to key populations, if you engage him and his team, then hostile practices in that district cease until maybe they bring in a new DPC. So this has been occurring in a bit non-structured way. But now we have partnered with the South Running secretariats. They're giving us technical assistance to develop advocacy tools, a guideline that can be implemented even when the Ministry of Health is not there, to be implemented by civil society, by partners who are supporting key population programs, to engage even in the farthest districts down there in Nsanje, assuming you are in the wrong way. So to engage the distant districts where the key technical community leaders may not be, we are coming up with a structured tool that we shall be using to engage all the police officers, all the authorities that are responsible for making decisions on whether to attack or to harass the key populations. We hope if this engagement is done, maybe these acts of violence and stigmatizing behavior may reduce. There is so much effort ongoing. And I think I want to invite one of the community leaders, Richard Lusimbo, to add to that, really, of the efforts going on. Richard, can you kindly, yeah.
Thank you so much, Dr. Daniel, and also for the question from our colleague. Just adding on, just as Dr. Daniel said, we are in the process with the support from South Planning to the Secretariat. We'll be able to have a tool designed to help us how to engage. But also what we've been doing currently is that different KP-led CSOs and partners have been conducting police trainings in different regions, and they've had conversations, they've held dialogues, and through this, we've been able to see attitudinal change and also some form of learning and understanding. But now we want to take that one at next level, whereby as opposed to just having different curriculums, but also dealing with issues of people being transferred and then getting back to ground zero, we are going to have this document that will guide us, but also engage, for example, the police and other stakeholders at the highest level, but also the lower level, to ensure that also even where the police and these other law enforcers study from, they actually have a space to actually have a study on key populations. And we hope that through this model or way, we should be able to address issues whereby we lose partners because they've been transferred. And this also sometimes even applies to healthcare providers, whereby you train in this health facility and then they're transferred and then you get to ground zero. Yeah, thank you.
Dr. Mudiope, is that an old hand? I think we are ready to close this discussion. Dr. Mudiope, that should be an old hand. If it's not an old hand, could you please make your submission as we close this meeting? Thank you, Dr. Mudiope. Thank you, Dr. Kyambadde and Richard Lusimbo and Macklean for sharing with us what is going on in Uganda. We thank our colleagues who are from outside Uganda for being a good audience. We invite you when the COVID pandemic has ceased. There are very few infections, less than 50 in Uganda. So it looks like we are going down to ending the epidemic of COVID-19. We invite you to come and visit us and see what we do for the key populations. And of course, I know Malawi myself. I know up to Marosa and the Kinamari. So I look forward also coming to visit and see how much you're doing for key populations and learning from you. Dr. Mudiope, you have something to say as we close?
Yes, Mr. Chair, as you close, I have some question on how reporting is done at EICs, and I think this is where we have a challenge as well, especially the community DICs or on activities that are purely not biomedical or behavioral, but issues to do with education and other HIV prevention methods. And also the issue of the peer educators, like looking at their accountability framework. I think somebody, is it Maulana, who asked that question? I think that's a challenge across, and going forward, I heard from Kenya. I think that was the Pari talking about the micro planning for peer educators and determining how much of their work, how can they be engaged. I think this is an area where we need to emphasize and help out, make sure that there is meaningful engagement of the peer educators, and also for their work they do. Thank you, and back to you.
Thank you, Dr. Mudiope, for that clarification. We thank you, our guests, for being a very good audience. We look forward to continued interaction and learning from each other. For us in Uganda, it's coming to 5 o'clock. We have to start moving back to our homes. We wish you a very good evening. Thank you for being our guests.
On behalf of the South to South Learning Network, I would thank Dr. Daniel for being a fabulous moderator and a facilitator. 2 hours went by, and thanks to your great facilitation. And I would also like to thank all the presenters from Uganda, Dr. Peter Mudiope, Dr. Peter Kyambadde, Richard, Macklean, Kyoma. Thank you so much for all your effort in putting up all these presentations, and of course, presenting it today, and then answering several questions that we had for you. Thank you for the participating countries. I will encourage you to please participate in this poll so that we can give feedback to our colleagues in Uganda, whether you liked the session or how you felt about the session. It always helps us to improve what we are doing. And as you finish your poll, I would just say, travel well home, for all those who are traveling from office to home, and all those who are sitting at home and working from home. Now I think you can switch off your computer and have a great evening. Thank you again, Uganda team. We are very, very grateful for this session that you led today. Asante.
Thank you.
Thank you.
Thank you. Bye.
Thank you.
Bye.
Thank you.
Bye.
Richard.